welcome to the May Life Unites Us webinar, Pregnancy, Stigma, and Opioid Use Disorder, or Reducing the Stigma of Opioid Use Disorder for Pregnant and Postpartum Individuals. My name is Michelle Juma, Project Management Specialist at Shatterproof, and we have a fantastic 60-minute event prepared for you. Feel free to use the chat box to introduce yourselves and include your name, organization, or city. We'd love to see who's with us today and who's a part of the audience. So as folks join in, I'll go over a little housekeeping, but we'll say that this event is being recorded and will be available on the Life Unites Us website. Folks will be muted throughout the event, so we won't be unmuting anyone's microphones, but you could submit any questions using the Q&A box at the bottom of your screen. The chat box is also available, but we won't be moderating it as closely. So any questions you have for Q&A, we suggest you use that feature. For best audio quality, consider listening to the webinar via phone line. So you would want to switch from computer audio to phone audio, and that should solve for any connection issues so you can hear our speakers throughout the event. Today's agenda includes a campaign overview and then brief introductions before our speakers are presented to us today. Then we'll open for a 15-minute question and answer, and then wrap at approximately 2 p.m. or 1 p.m. Eastern time. So with that, I'd now like to introduce Ashley Narvaez, who's the program manager for Life Unites Us, and who will provide an overview of the campaign.
Hi, everyone. So happy to be here with you all today. Thank you for joining us. We're very excited about our program. For those of you that are joining us for the first time, my name is Ashley Narvaez. I work on the community engagement portion of the Life Unites Us campaign, and I'll just spend a few minutes telling you about some of the work that we've done in the state so far. So Life Unites Us is a substance use disorder stigma reduction campaign in the state of Pennsylvania. We are statewide. Our goal is to increase knowledge and education and decrease the stigma associated with those living with OUD in the state of Pennsylvania. And the way that we do this is through story collection. So the bread and butter of our campaign is working with individuals across the state to share their stories of recovery in the hopes of really honing in that messaging that recovery is probable and possible, that addiction is like any other chronic disease and is treatable, and changing some of those perceptions that we're all too familiar with. Next slide, please. And this work wouldn't be possible without organizations like yours. A big portion of the work that I do personally for the campaign is building relationships across the state with community-based organizations, or CBOs as we call them, to build relationships and make sure that not only we are spreading the reach of the campaign and our messaging, but also that we are making sure the campaign is being guided by the needs of the community. To that end, we have a community impact committee made up of representatives throughout the state, different CBOs that provide guidance and feedback on our initiatives and our messaging. And we also try to be a resource. So this webinar series being an example of some of the offerings that we have in place. Next slide. So if you haven't connected with us yet, I'd really encourage you to do so. We're on all the social media platforms, Instagram, Twitter, and Facebook. I would encourage you to visit our website, look at our story library, become a partner. Happy to build very mutually beneficial relationships so we can collaborate. And with that, just the next slide. So just one final pitch for Shatterproof. We are hosting a Stigma of Addiction Summit on June 8th. It should be a very exciting program by the agenda that we have. I'd encourage you to register if you haven't done so already. Michelle has put in the registration link in the chat. And with that, I'd like to introduce our speaker for today. So we are joined by Dr. Gary Stoner that we're very excited to have with us today. He is the director of Women's Health Opioid Use Disorder Program at Geisinger Medical Center. He specifically asked me to keep this intro short, although I could go on and on. But Dr. Stoner, I will hand it over to you now.
Okay, thank you. I'll go ahead and share my screen. Alrighty, the next 50-some minutes will melt by quickly, so I will jump right into it. The learning objectives for this presentation are to identify the long-term maternal and infant health outcomes with opioid exposure, to combat addiction in the care of the pregnant and postpartum individuals with opioid use disorder. And you'll be hearing firsthand from a former patient of mine and now colleague who has been through our program, and to learn a little bit about our Free to Be Mom program, which is pretty consistent with a lot of other programs that institutions have. If Maya Angelou were with us today, this would be her objective, which I totally agree with. And I will try my darndest to help all of you feel this lecture. When you think about our lives and what we've done, you often forget the specifics of what people said and what people did, but you will never forget how people made you feel. I just want to be like a normal person, Dr. Stoner. I hear this quite frequently, and I think it's a sad commentary for people to believe they are not normal. When patients come into our office, our first clue is visual. That's all we have to go by. And as all of you look upon these pictures as I just put them up, you are already formulating thoughts and stories about what you see in these faces based on your background, your perspectives, and the things that have been trickled into you over the years. Whether or not those stories are accurate, and they're probably not, it's the first false judgment we make about people. Not in every patient, but as a general core, trauma is a common foundation in patients that make them start down that journey of making poor decisions in their lives. And what is some of the trauma that our patients have been subject to? It usually starts young. And this is just an example of some of the things like bullying, feeling shamed, not feeling part of the group, peer pressure, having interpersonal relationship problems. They're in the lower left, not having appropriate role models, and just having fear about life. And it leaves our patients feeling shattered. It leaves our patients not feeling whole, hence their comments to me about, I want to feel normal. What we do when we are looking for relief in our life, we tend to want to escape to something. We make a choice, something that makes us feel good, something that makes us normal. And when that choice does, we repeat it over and over and over again until it becomes a habit. And if we are unable to change that habit, then we essentially have ourselves an addiction. And in the management of patients, particularly with opioid use disorder, it's imperative that through the process of their management, we always circle back to understand what is the basis of the trauma those particular patients had, from which they felt the need to escape, and hence the choices they made. And what are the choices? Well, in the upper left, we're here today to talk about substance abuse, but there's a myriad of things we all can identify with. Shopping, a favorite growing up in the Stoner household was food, internet addiction, caffeine, gambling, alcohol, tobacco. It goes on and on. It's a head thing, Dr. Stoner. This, again, is not an anecdotal comment that I hear. That's me in the Stoner household, growing up, getting myself into a situation that I don't want to be in. And that's the expression and the way we look when we find ourselves in a capacity that we don't want to be in. So what is this particular person thinking? What we all know is what got us into the mess we're in. And how do we change that around? Well, we can, but it takes a lot of factors. It takes discipline. It takes the desire to do so. It takes support. It's not impossible to do, but it is very, very difficult to change our habits. And what our patients hear, not only from the public, but from health providers as well, is you chose this. This mess of a life you have with drug addiction is something you chose. Really? But that is a common thing that we hear. So let me ask those of you on the line, and when I do in-person meetings and I get to this slide, the question I ask is, how many of you would choose this in your life when you're driving home from work today? This mess, this car on its roof, this is exemplary of the mess you let your life to come into. I never see a hand go up. No one ever admits to it. But when I ask, how many of you would choose this? How many of you have chosen this? How many of you continue to choose this? You see people squirm in their seats, squint their eyes, get a little uncomfortable because now they start to feel the problem. And we know it kills 3,600 people, approximately 3,600 people every year. Yet we continue to do this. Why don't we stop? So I submit to you, we all have an opioid-like addiction. This overwhelming preoccupation and interaction and obsession with our iPhone devices. Did you ever leave home without your phone? I'm sure you did, and you absolutely go into a withdrawal. There are probably some on the line right now distracted by their cell phones. I take no offense, we all do it, but we are addicted to these electronic devices. So who's vulnerable to whatever? We certainly can't tell by looking, even if everyone looks the same. And we certainly can't tell by looking, even if everyone looks different. When you think about the definition of drug addiction, it is very polarized. On one end of the spectrum, people feel it's a disease. It's a chronic relapsing disease. It changes the brain chemistry, and it's all about dopamine. And these are all scientifically proven. The cognition, the ability to reason is gone. The drugs have hijacked the brain. And I use the word hijack not flippantly. This is in the literature to explain how the cognitive function is gone. On the other end of the spectrum, people will say it's just a lack of willpower, it's a moral failure, it's a habit. So where does the truth lie? Like most things in life, it's a spectrum. And where any of us lie on the spectrum of how we look at this problem is a combination of what our perspective is, what our prejudice is, and the truth we want to put behind the science. I could call my lecture a time for the rebirth of self-reflection, because I firmly believe that in order to understand this problem from the patient's perspective, we first have to understand it from our perspective and what our prejudice is, and most importantly, do we impose judgment, either knowingly or unknowingly, on our patients? So this is a patient who comes into the office, and you look at them and say, you know, something is wrong here. This does not look normal. But it takes a little bit of time and introspection to understand why this patient looks like this. Because once we learn more facts, we realize, aha, there is nothing wrong. This picture was not photoshopped. We were just looking at it from the wrong perspective. Prejudice is an unfavorable opinion or feeling formed beforehand without knowledge, thought, or reason. Here's Mr. Judgment. This is not the person we feel comfortable standing in front of. This judgment that is imposed is done on the foundation of the fact that we judge others by their behavior, but we judge ourselves by our intentions. And I think this is put forth very well by Stephen Covey, the author of The 7 Habits of Highly Successful People. And what this judgment does, it causes stigma in the patient. They feel on the periphery of life. It makes them feel broken. It makes them feel not normal. Thank you for not judging me. You turned a situation of a pregnant mom who was terrified of telling anyone about her addiction into a more confident one who strives for her recovery. This was written to us by Tiffany, a patient I had the privilege of managing a couple years ago who did phenomenal in the program. Unfortunately, at 36 weeks, she showed up to labor and delivery and there were no fetal heart tones. We had to induce her, and she understandably lost it. She felt remorseful. She felt she caused it. I've been in obstetrics for 30 years. It was not her fault. This happens, unfortunately, in any patients, but she blamed herself because she had used drugs. And the remarkable thing about Tiffany was she did not resume or relapse into any reuse of substances. And I give her so much credit. When we see behavior in people that doesn't seem to add up, our innate sense is to ask ourselves about that behavior, what's wrong with you? And I submit that the construct of how we look at patients has to be what happened to you, because deep below that behavior lies the trauma. My babysitter, who was my aunt, gave me heroin when I was 13 years old. This was told to me by a patient who was in her early 30s, who was pregnant, and had been judged and given the label of being a drug addict for some 20 years through absolutely no fault of her own. So what we see and what stories we make up to try to tell ourselves about that patient is not what the patient feels. It's a much darker side of life for the patient. So we have to listen. We really, really have to listen to the patient. Fortunately, in my role, I am a part-time physician now, but 100% of my part-time status is solely dedicated toward the care and management of pregnant women with opioid use disorder. So I have a lot of time to listen to my patients and get the information that is absolutely critical to help patients successfully work their way through a program of opioid use treatment. But that's typically not what happens in our health systems today. Patients come in with all the baggage they carry, and after a very short period of time, summations are made, and it's like, well, just stop it. Why don't you just stop? And you hear that from the public. Well, stop picking up that cell phone that's going to ring tonight in the passenger seat as you're on your way home. Opioid use disorder knocks on the front door of everyone's home. We either know someone personally or we know someone who knows someone who has opioid use disorder. And just because you're pregnant, it doesn't exclude you from this problem. And the drugs that pregnant women take that are transmitted to their babies is something that is one of the most fearful and riveting aspects of what ironically helps to bring women to treatment. They worry about the neonatal abstinence syndrome, or more appropriately called the neonatal opioid withdrawal syndrome. This is handled by the pediatricians, obviously, but if we don't do our best in the prenatal clinics to maintain patients' adherence in our programs, the likelihood of NALS occurring in a baby is much higher. As a matter of understanding, the diagnosis of NALS has been traditionally been predicated on the Finnegan scoring. I do not do Finnegan scoring. I am not a pediatrician. Our nurses do the Finnegan scoring. But what I am starting to learn about it and hear about it, it is a cumbersome matrix of data. And you can see here on this slide, the factors of which a practitioner is looking at a baby and trying to deduce, is this baby having withdrawal or not? A whole lecture could be dedicated towards this particular aspect, but I want to just put this forth as something that probably many of you are familiar with. What we are moving to today across the nation, we are doing this at Geisinger, as some of you may be aware, is the Eat, Sleep, and Console. to distill this cumbersome matrix down to 3 basic elements. Can the baby eat? Can the baby sleep? And can you console an irritable baby? And if these 3 factors do not seem to be an issue, the baby most likely does not have NAS and will not need treatment. So that is the superficial view of this, but there's more data to come out. But I hear it from patients who have gone through this process that the eat, sleep, and console is something that is extremely well perceived and received by the patients as well as the providers. This is the patient who is put into the room by my nurse and closes the door. The patient who sits there with fear and anxiety on their mind, wondering who is going to walk through that door and what are they going to say. And the thing I like about this slide is this window. This to me represents the window of opportunity for me as a provider to make or break the successful journey that this patient is about to embark on. The words out of my mouth at this juncture to every patient I meet for the first time is thank you for coming. Thank you for being here. You are doing the right thing. We can help you. And we have taken patients from the utmost of despair on this merry-go-round of drug use to patients who are happy and healthy. Who you see in this bottom picture is Alyssa. That is her baby, who is now 3 years old. Alyssa did remarkable through the program and stands as a shining example in my mind of the difference that can be made in the lives of people with addiction. And how is it done? It's done by a team of people, all hands on board. In this picture, you see physicians, pharmacists, front office staff, case managers, social workers, certified recovery specialists. We are so fortunate at Geisinger because we all stay connected. We all have everyone's phone numbers. We all are on board together to work with each and every patient who comes through our system. And I might add, every patient has my personal phone number and can contact me at any time by text or voice for whatever problem arises. It cuts out the middleman, and I know what's going on in real time. I'll briefly mention that Geisinger has a program called Free to Be Mom, and this is consistent with many programs that I hear about throughout the nation. If you Google Free to Be Mom, helping mothers in the battle with addiction, you will see approximately a 6-minute news segment by WNEP, which includes myself and Alyssa, who you just saw, in regard to what our Free to Be Mom program is. It's a program that follows moms, babies, families for 2 years. The patients can be pregnant or not pregnant. They can be on a medication for opioid use disorder, or they can be abstinent from all illicit use or the misuse of any drugs. And it's a wonderful program, and it just keeps building. It's county-based, it's funded by county, and it's headed by remarkable people who, in my opinion, make a tremendous difference in the lives of our patients. We all know that the choices we make are not good ones. We try to minimize them. We try to put them in the rearview mirror of our life. And there are no greater choices that have been wrong in the lives of our patients who are addicted to opioids. And to turn them around and to make them believe in themselves and understand that their future does not have to be as dim and glim as what they feel it currently is something that takes a lot of time and is difficult to do. They did not judge me. They got eye level with me and believed in me when I did not believe in myself. This was written to us by Brittany, a patient we worked with about 6 years ago now, who had a very rough course throughout her pregnancy, had a difficult time staying away from the illicit substances, was admitted to the intensive care unit, but ironically, in the end, she actually did very, very well. And to use the terms got eye level with me, what would make any of us write that to another person? That, to me, is a very telling bit of verbiage, that we looked into her, we looked into her soul, that we really understood the problem from her perspective. I find that very powerful. This is our patient who presents underwater, suffocating, and the only thing that they can think about is air. I need relief from this merry-go-round that I'm on. And my job, job number one for me, is to, in a sense, get them breathing again, get them feeling good, get their cognition back. And we do that first by working on the brain with MOUD, medication for opioid use disorder. I work strictly with buprenorphine. I do not dispense methadone. There have been studies between methadone and buprenorphine, again, which is an entirely other lecture, but it is a remarkable medication that can really stave off the cravings for opioid when you can finally begin the journey of then working on the behavior with the counseling and the social support, which is equally, if not more important, to help our patients. This is me and my nurse and all those wonderful people I showed in the slide, digging our way to find the diamond in the rough that I believe exists in all patients. But the roadblock that can be put in the way for that to be successful is doctor judgment. This is not the provider you want to see walking into the room. This is not the provider our patients want to see. Without saying the word, this physician is saying, you know, you're bad, you're wrong, you're not normal. This is not what we want to project. This is the projection. This is the body language. Thank you for coming. Thank you for being here. You are doing the right thing. I would be honored to send a positive message to our community and be an advocate of how this program has saved my life and could potentially save the lives of others if they are willing to fully commit. And this was written to us by Alyssa, who you've already met. And what I find powerful about her statement is if they are willing to fully commit. Alyssa was willing to fully commit, and she turned her life around. And that is the second roadblock that is put in our path in order to help find the diamond in the rough of all of our patients. And that's if the patient is not willing to fully commit. There is nothing that we can do. And it's frustrating, but the old adage, you can lead a horse to water, but you can't make them drink. All we can give them is the opportunity. And therefore, what we have learned from Brittany, get eye level with me, understand who I am, see it from my perspective. And from Alyssa, I have learned that we can extend our hand of compassion as a healthcare system, but the patient must extend their hand of commitment. I want to finish up here by saying that I see the opioid crisis as this: starfish washing up on the beach, dying. And the old adage of the father walking along the beach with his daughter, and he watches his daughter pick up each starfish, placing it back in the ocean, trying to save it. And the father says, honey, what are you doing? Look at this. Look at this mess. How can you possibly clean this up? The CDC statistics from last year said that 100,000 starfish have died because of opioid use disorder. But what the little girl knew that the father didn't know is that these starfish were not statistics. They were individuals. They had names, they had lives, they had families, they had goals, aspirations, just like all of us have. They did not ask, in my opinion, to have the mess they had in their lives, and they need our full attention, our kindness, and our compassion, because it matters to that one starfish. And actually, it matters to two starfish. It matters to the mom, and in the case of pregnancy, it matters obviously to the baby. And beyond that, it matters to the entire family. This is myself in the background with the ball cap, and in the front there in the ball cap is one of my nurses. That's Alyssa in the middle with her mom and dad, as we were at a Walk for Life a number of years ago. And more so than mattering to the family, it matters for the education of future healthcare providers. That's Alyssa on the right in front of 30 nursing students at Bloomsburg University a couple years ago, bravely telling her story about her road to recovery. And that's her mother there in the left slide, telling the students of the family dynamics of opioid use disorder in the family. Fear and stigma, in my opinion, are the rate limiting steps. We do the best we can until we know better. Then when we know better, we should do better. It's a moving target. It's continual learning. I think what Maya Angelou has to say here applies to this topic. I would stress again for all of us to look in the mirror at our own addictions, if I can use that word, and find the aha moment to be non-judgmental and compassionate towards our patients. The goal isn't for them to just be sober, but it's to build a life from which they don't feel the need to escape. Here's a summary that I call the summary of core pearls of management. I won't go through them. They are included in this slide deck and will be available to you. They are in these two slides here and also on this one. And I want to conclude by just sort of expressing to you the difference that I see between two patients. I'll call them patient one and patient number two. Patient number one, I saw back in 2015. Patient number two, I saw recently in 2020. And for each patient, we poured in this rainbow of opportunity. Yet the patient in 2015 wasn't happy. They weren't showing up for appointments. They weren't compliant and adherent, I should say, with their ultrasounds. They were altering their urine. They were lying. They were still not quite released from the use of illicit substances. And it was a bit of a rocky road, but nonetheless, the patient actually did well. So with all the same rainbow of opportunities, I can describe patient number two, which was totally different. The patient was very compliant, showed up for appointments. Urine toxicology screens were always appropriate. An absolute pleasure to see this person every single visit. So what is the difference? What makes the difference in the disparity as I'm describing in these two patients? Well, what I would like to do at this point is introduce someone who is going to help explain this. And I will ask Felicia to turn on her camera. This is Felicia, who is a former patient of mine, but like Alyssa, she is now a colleague of mine. And I am so proud of her. I'm getting goosebumps as I see you, Felicia, for all you have taught me and mentored me along. And I would like you to explain to these folks the difference between patient number one and patient number two.
Well, I would like to first say that both patients were myself. In 2015, I was not ready to fully commit to getting clean. I was living with an abusive husband at the time. He's now my ex-husband. I had a lot of trauma going on. I was getting beat daily. He was trying to control me with the use of narcotics, and I couldn't fully submit to getting better. I was scared of doctors. I've had judgment in the past from doctors. So going into Geisinger, I felt like it was going to be the same thing. And I did not give anybody a chance. Now, going forward to 2020, I had gotten rid of the husband. I had become pregnant again, and I was fully willing to commit myself to recovery. I did not want to live like that no more. I was tired. I was broken. I have not been happy in any of my lifetime at all. And it was just time to get away from the hurt and pain. So I remember that, you know, when I did go to Geisinger in 2015, that I worked with Dr. Stoner, and Dr. Stoner, I can remember it wasn't judgmental. So I went back there, and sure enough, you know, Dr. Stoner was just as amazing as he was back then. I just couldn't see it yet. So I was able to commit myself and do well in the program, and I'm still clean to this day. I've been clean for about 4 years now. I, you know, struggle a lot, but, you know, I have a great support system. Once I was able to fully commit, more people started trusting me, started helping me, was there for me. And that's what makes the big difference in my life today.
Felicia, I want to pick up on two things that you just said. You said, I was scared. Can you
Yes.
verbalize specifically what it is you were scared about?
I've been to the hospital a couple of times before that to try to get clean, because I was tired of being, at the time, it was just that I was tired of being sick. So I would go to the hospital, and I would immediately, like, you know, nurses would look down on me, like, you know, they would talk to me disrespectfully. When I did have a baby and I was on drugs and didn't know about like Subutex or methadone or anything like that, I had a rough delivery. They were constantly coming, and I had stopped using before I gave birth. So that way, like, you know, I could, like, I weaned myself off the drugs so that way I could have a baby that was not withdrawing, that was healthy, or so I thought. But 3 days after I had weaned myself off, I went into labor, and baby still was withdrawing. So the nurse was constantly coming in my room and drug testing me, and I really wasn't using, and I was clean. They called children and youth on me. They just made it really hard. Like, I also went in one time when I was sick trying to get help to go to rehab, and the nurse was not believing a word I said and was being very smart to me. So when I came into Geisinger in 2015, I thought, you know, all doctors are the same. They don't, you know, they're not going to give me a chance. They're not going to believe me. They're not going to accept me for who I am.
Could you give an example, Felicia, of some actual words, if you can remember, of the judgment that the providers actually said to you?
I can't remember their exact words. I just remember how they made me feel. I remember that I was very upset. I was crying. And then after I left the hospital, of course, I ended up using again, because I said to myself, like, you know, what is the point? What is the point if nobody is going to help me? What is the point if nobody believes me? And if I get talked down to like this, I'm never going to be able to stop. I'm not as good as those people are. I felt very like I was beneath everybody.
Well, thank you for paraphrasing what I just presented about Maya Angelou. You just said you couldn't remember what they said, but you remembered how they made you feel. And that to me is everything.
Yes.
And Felicia, if there was ever just one thing that you could sort of, I know there's a multitude of things, and having support, personal support in your own life is so critical. If there was one thing that you could hang your hat on, that you maybe felt sort of threw the switch to change you from patient number one into patient number two, what would that be?
What do you mean?
Like, was there any one particular thing that finally made you think, I have to straighten up and get off this merry-go-round? I can't continue
Yes.
like anymore.
My kids were getting older. They were starting to hate me. They were sick of the broken promises. I was about to have another child, and I just was like, I can't live like this no more. I'm 30, I was like 35 at the time, and I felt like I couldn't do it no more. It was time to grow up and, get my children back to where they needed to be with me and get my relationship back with them. Those were my babies. I had lost 3 of my kids to adoption as well. So it was very hard to see my other kids not have me as well. And now I have 3 kids that I will not see. And hopefully, just hopefully, they will come find me when I'm 18. And I don't want them coming back to find a mother who is still getting high and on the street, or possibly even dead, because I wasn't going to make it much longer. I have no more runs in me. If I go back out there again, I will die. And I'm not willing to do that. I'm not willing to leave my children without a mother, or my other children to come find a mother that is not there no longer or still in the streets.
You really feel, Felicia, that would have been the course of your life had you not had a treatment program to go into?
Absolutely.
Wow. I want to say to those listening, as I listened to you speak, Felicia, I remember in 2015, the time you got up out of the chair, you said, I can't do this. You went to the door. I remember touching you on your shoulder, trying to say, we're here, we can help you. And then you came back about a half hour later, and I thought, wow, this is never going to be, wow, this is just isn't working. And here we are today giving a webinar to people. And I would like to, just to mention to the people that you are now the manager of 3 pet stores and a very active and busy person in quite a thriving business. And, I am just tremendously proud of you, Felicia, for the boldness and the bravery you have to come forward and tell your story, not only for, how you have helped yourself, but how you are now helping others. So, thank you for being a patient of mine, a friend of mine, and thank you for being my colleague.
No, thank you for being such an amazing person and helping me get through this, Dr. Stoner. I really appreciate you.
Well, thank you for those nice accolades, but it's a team. It's really a team approach. So at this juncture, I'm going to turn this back over to Michelle. How would you like to proceed?
This is great. Thank you so much to both of you for your presentation, for Felicia for sharing your story. If you check out the chat box, there are so many messages of support, people sharing their own experiences. And I'm just really happy for the space that we've been able to create here today, where people can share openly and honestly, and hopefully can continue to bring this into their own work or personal lives. But we do have questions coming through. So I'll actually invite Ashley to come forward and help me read some of those out as I filter through the next ones. But if you could submit any other questions using the Q&A feature, please do so. I'll go back through the chat and see if I missed anything. But Ashley, could you ask our first question?
Yeah, thanks, Michelle. And I just want to echo Michelle's words, Felicia. So happy to have you share your story. So thank you so much for being vulnerable in that way. And to you as well, Dr. Stoner, for your presentation. So we have a couple of questions that were directed at you, Felicia. Some members of the audience were wondering if you could speak a little bit to your experience with medication for opioid use disorder while you were in the program.
The medicine was amazing. One of the biggest things I was worried about was the withdrawal for the baby. So when I had him, I went into the Bloomsburg Geisinger and I did the Eat, Sleep, Console. and I didn't have any issues with withdrawal whatsoever. The baby did amazing. There was no crying, puking, nothing from the baby. One of the nurses there told me that they did not have to use morphine one time to wean the baby off. So the medicine was amazing. It did amazing. I had no cravings. I did not use not one time during my pregnancy, and I took my medication like I was supposed to. I also did the counseling, which helped a lot. I have a lot of trauma in my life, so without that and the medicine, I'm sure it would not have worked. It is a hand-in-hand thing you have to do with the medicine.
Absolutely. Another question that we got were relating to plans of safe care. So in your experience, did you find that using plans of safe care helped you in your road to recovery? I know that you mentioned at the beginning, the relationship that you were in, it's not a safe one. So did you utilize any of that in your road to recovery?
Yes, I was in a way better relationship and a supportive fiance that helped me through this. He's also in recovery. So we help each other and we push each other forward. So getting rid of the negative people in my life helped me push forward instead of staying in the same place.
Thank you. Just switching over to Dr. Stoner really quickly, we had a few participants that were interested in learning a little bit more about the Free to Be Mom program in terms of what patients can be referred to it. So is it specific to the Luzerne County, or can any patient be redirected to that program?
Yes, the program started in Luzerne County, and as I had briefly mentioned, it is grant funded per county, and I'm on the periphery of Free to Be Mom just from a clinical perspective, but the Free to Be Mom program has spread to Columbia County, Northumberland, Union County. They're trying to get into Juniata County, Montour County. At last count, we pretty much have meetings every 2 weeks. I understand there was some close to 200 plus patients who were in the program. Most of the counties have both a case manager and a certified recovery specialist who work hand in hand to go into the homes of patients. They work on housing issues, financial issues, legal issues, food issues, transportation issues, car seats, and the medication, how they were doing. I usually get consulted from a medication standpoint, but it's a wonderful program. I'm not the spokesperson of it who knows the intricacies as well as those who were more involved with it. People often ask how we got our program going, and to me, the success of our program is all predicated on the individual providers. We are also well connected. As I mentioned, to me, it's only successful if all the people are truly vested in wanting to help. And that just sort of fell out of the sky for us just naturally, which is what it takes. It's something you can't force or create in a person. It has to be innately there, and once it's drawn out, there's just sort of no going back.
And I know that there's some interest in terms of how to get this program expanded to different counties. Is that something that you could possibly speak to? If not, I'm sure that we could also connect with your colleagues who run the Free to Be Mom program and provide some of these answers offline as well.
Yeah, that certainly, Ashley, is the way I would direct you. I am not privy in those circles to the grant funding and the people who are connected to make this happen. When we have meetings county based, there are people there from United Way, the local jails, food service individuals, clothing people, housing people, to use a sort of a general template. There's a lot of people involved in these meetings, and that's all different between the counties. And the individual who sort of investigates all of that is not me. So reaching out would be the best.
Yeah, of course, we'll definitely do that. And just one more question for you, Dr. Stoner, before switching over to Felicia. Again, the questions are really starting to trickle in. But you talked briefly about diagnosing a baby with neonatal abstinence disorder. Do you know if there's any research related to how often a baby is diagnosed with NAS when compared to having white birthing parents versus Black birthing parents?
No, I'm sure there is some degree of disparity. I do not see a lot of Black parents within my scope of practice. I will see anyone who walks through my door, but just through the geography of where I am. But nationally, I'm sure someone is looking at this. But here's what I can say, Ashley, that I think is of absolute critical importance. The babies that do not do well are moms who are not in programs. Right now, as I speak, we have a patient on labor and delivery who used fentanyl right up to the time of her admission. She had my phone number. I had her phone number. I kept after her. I texted her. I called her. She just wasn't ready. Her baby is now experiencing NAS. It happened to a patient 2 weeks ago who came in to see us. She was not in our program. We knew nothing about her. She showed up on our doorstep. All the patients in our program, knock on wood so far, who have been adherent in our program and have done well and have not had their urines mixed with illicit substances, none of their babies have had NAS. They actually deliver at our sister hospital in Bloomsburg that is positioned very well from a bricks and mortar standpoint to take care of moms for the recommended 5-day stay that babies have to be at the hospital and monitored for the development of NAS. So I'm giving you maybe a little roundabout answer, but it just bespeaks to me the importance of an MOUD program.
Yeah, of course. So back over to you, Felicia. Just a couple more questions for you. Do you have any suggestions for providers on how they could work with a patient who may not be totally convinced about going into treatment yet?
Just being persistent and genuine. When I came back to Dr. Stoner, he was still very persistent with me. And just by the way, he was genuine with the way he talked to me. He made sure he had time for me. He reassured me that, he was there for me to help me. That helps. A lot of times when you're feeling judged by a doctor, you can tell that they just don't care. They'll be very quick. They'll be rushing you. Their attitude is completely different. Just showing you're genuinely care for that patient is a big thing.
Yeah, absolutely. In your experience, once you gave birth and you were in the program, did you find that the way that you were treated by healthcare providers was different?
Yes, Dr. Stoner was just talking about Bloomsburg. That's where I delivered at. The program there is amazing. A lot of the nurses are trained to deal with mothers who have addiction problems. They were absolutely great. They were very caring. They constantly, came in and checked on me to make sure I was okay, to make sure I was feeling okay, make sure the baby was doing good. So that made a big difference.
Thanks so much, Felicia. Just a few more questions now on the programmatic side, Dr. Stoner. Does your program practice hepatitis C testing and linkage to care?
Sorry, hepatitis B? C, absolutely. It's, as you know, it's extremely common. I would be, for a patient who would come in who admitted to injecting it would be amazing not to be hep C positive. And we get them into our hepatology clinic, and some maintain adherence, some do not. But yes, that is critical. Hep C, very common.
Thank you. And then just another more technical question. I knew that someone had a question on high risk of SIDS being from a family of multiple births. So for example, if a fifth baby is born, do they have a higher chance of having NAS? If you could speak to that.
Wait, I'm sorry. The question is if a baby.
So is it true that after multiple births of a child being born, same children within the same family of having NAS, do the chances increase of a child being born?
Boy, not that I'm aware of. It's a piece of research that I don't follow. Probably pediatricians would know that better, but to my knowledge, no. I wouldn't understand what a link would be there.
Thank you for that. I think we've covered all of the questions that we have in the chat, which is great. Michelle, is there anything that I might have missed?
That is everything. So I want to thank everyone who has, let me turn my camera back on. I want to thank everyone for joining us for today's session. Thank Dr. Stoner, thank Felicia, thank Ashley for helping me out with this session, and for everyone who is offering the support and kind words and resources in the chat box. We will be recording the session, posting it online, and also in the follow-up email, you'll get a copy of this presentation. And as you close out of today's event, we also are asking you to complete a survey. We want to continue to have great sessions with topics that really do apply to your work, and help us continue to improve the resources that we offer through Life Unites Us. But thank you. And I hope you all have a great day and join us at our next event.
Thank you all.
Yes, thank you.
Bye-bye.